Hey everybody, welcome to the Next Gen NCLEX-RN review. Today we'll tackle clinical judgment cases and share expert tips to help you pass the NCLEX-RN. Make sure to focus on enhancing your test-taking skills and building confidence. So let's get started.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere, at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
Here's our first item, and this is a Bowtie question. So here we go. We have a case of client that is admitted, 68-year-old male that is admitted to the medical surgical unit. That is post-op day 7 following a total gastrectomy for gastric cancer. The progress notes says at 7:45 in the morning, patient reports sudden onset of severe abdominal pain at 9 out of 10 pain scale and nausea. Post-surgical abdominal dressing was noted as dry and intact. Vital signs recorded as blood pressure of 96/68. Pulse rate of 117 beats per minute, respirations 24 breaths per minute, temperature of 101.8 degrees Fahrenheit, saturation of 93% in room air, abdomen is rigid on palpation, nasogastric tube output is 200 mL of cloudy fluid in the last 4 hours, reviewed with patient current pain medication, morphine 2 milligrams IV push every 4 hours PRN, severe pain, and ondansetron 4 milligrams IV push every 4 hours PRN, nausea and vomiting. At 7:50 in the morning, patient reassessed. Vital signs now blood pressure 84/58, pulse rate of 125 beats per minute, respirations 28 breaths per minute, temperature of 102 degrees Fahrenheit, saturation of 88% room air, administered ondansetron 4 milligrams IV push. So your task is to fill in the diagram by choosing from the options provided to identify the potential condition the patient may be experiencing, 2 suitable nursing interventions, and 2 parameters to monitor to evaluate the success of the nursing interventions. So for the potential condition, we have the options: acute respiratory distress syndrome, anastomotic leak with developing sepsis, hypovolemic shock, and post-surgical pancreatitis. Now, what do you think would be the most suitable potential condition here? Well, there's no other than anastomotic leak with developing sepsis. And why is this the correct answer? Well, this is something that can happen when the surgical connection, or we call that as anastomosis, between the stomach and the intestine fails. And so it will allow the contents like gastric fluid or maybe bacteria to leak into the peritoneal cavity. And this can lead to peritonitis and sepsis, which is life-threatening systemic infection. And the evidence for this potential condition includes the onset of severe abdominal pain. So that's actually in the progress notes. So let me highlight that one. Okay. Here we have the sudden onset of severe pain, 9 out of 10 pain scale. And this is a hallmark of an acute intra-abdominal catastrophe. And The leak will cause irritation or infection of the peritoneum. Another supporting evidence here is the rising temperature of 101.8 degrees Fahrenheit. And this increase in the temperature will actually go up some more, even in a short period of time. And this suggests an inflammatory or infectious process, which is consistent with peritonitis from the leaked contents. Another supporting evidence is the pulse rate of 117 beats per minute. The rising pulse is a reflection that there is stress response, likely from the pain, could be the ongoing infection, or hypoperfusion because of the developing sepsis. Another indication is the blood pressure that is actually going downhill. Previously, at 7:45, it was 96/68. 5 minutes later on, when the nurse reassessed the client, it went down to 84/58. And so the falling blood pressure reflects systemic vasodilation and possibly fluid shifting, which is common in sepsis where the body struggles to maintain perfusion. Another supporting evidence is the tachypnea. We have the respiratory rate of 28 breaths per minute. Previously, it was 24, so it's going up. And this suggests respiratory compensation for an ongoing acid-base imbalance. Could be metabolic acidosis, could be from sepsis and early hypoxemia. There's also that right abdomen, rigid abdomen rather, when the nurse palpated. Let me find that. So, where's that thing? Here we go. Abdomen is rigid on palpation. So this is suggesting that there is an ongoing peritonitis wherein the abdominal muscles tense due to the inflammation or the infection, which points to a leak. Now, another is the nasogastric tube output of 200 mL of cloudy fluid. Pay attention to that one. And that's have been going on in the last 4 hours. So the cloudy output could represent pus or contaminated fluid, supporting the idea of an intra-abdominal infection from a leak. Now, take a look into the scenario one more time about the post-operative day. We are on day 7. Okay, the client had a gastrectomy 7 days ago, and that this was indicated due to the gastric cancer. And the anastomotic leak will often develop around 5 to 10 days after the procedure, as the healing anastomosis weakens or could be failure under stress. Now let's pick into the other options here. Acute respiratory distress syndrome. Why do you think this is not the answer? Well, the reason that this is incorrect because with acute respiratory distress syndrome, this is a severe lung condition that is characterized by a rapid onset hypoxemia. Also bilateral lung infiltrates and respiratory failure, and this is something that is triggered by events like pneumonia, could be aspiration or trauma. But in this case, there's just a few supporting evidence that this is ARDS. Could be the low O2 saturation, right? 88% in room air. And the tachypnea. There's that 28 respirations. And these are just few of the supporting evidences for the ARDS. But the ARDS lacks the abdominal pain and fever as primary features. And with this, it typically follows a clear respiratory insult. Could be aspiration during surgery, which is not mentioned. And the rigid abdomen, the cloudy nasogastric output point to an abdominal source, not a lung issue. And so we are gonna discard this option. Put an X mark here. Now, what about the hypovolemic shock? Why is this an incorrect option? Well, hypovolemic shock can happen when there is significant fluid or blood loss, which will reduce the circulating fluid volume or blood volume, which will lead to poor tissue perfusion. Here, in this case, we only have a few supporting evidence. Could be the low blood pressure, right? 84/58, and the tachycardia of 125 beats per minute, which will align hypovolemia. However, the post-surgical dressing, according to the case, is actually dry and intact, right? And there is no mention of bloody nasogastric output. So I want you to go back into this piece of information here. It is only saying that there is 200 mL of cloudy fluid in the last 4 hours. If there's bleeding here, then the color of the nasogastric tube output would be bloody, but we're not seeing that. That's why the hypovolemic shock with associated hemorrhage is not going to match this one. Let me just erase that real quick. Okay, I don't know what's going on here. That's not really letting me remove that. Anyhow, the next option, post-surgical pancreatitis. Why do you think that this is not going to fit in here? Post-surgical pancreatitis. Well, this is something that can happen when there is an inflammation of the pancreas, which could cause epigastric pain that is radiating to the back, nausea, elevation of the enzymes, such as the amylase. But there's only a few cues that will support this, the abdominal pain and nausea. However, with this procedure, gastrectomy, pancreatitis is very rare unless the pancreas is surgically manipulated. And the scenario does not mention that one. And this doesn't typically cause a rigid abdomen or a cloudy nasogastric output or rapid systemic decline, such as hypotension or hypoxemia. Fever and sepsis are more suggestive of an infectious process like a leak than a pancreatitis. And that is why this is not also a good option. Now let's move on into the nursing intervention. So carefully select those two. And one of those actions include administer oxygen as ordered. So pay attention to the saturation of 88% on room air, which was initially 93% on room air. So it dropped in just within 5 minutes. And this indicates hypoxemia, which there is a sudden drop in the oxygen levels, which will be insufficient to meet the body demands. And this could stem from sepsis-related respiratory compromise or probably early acute lung injury. And so what you need to do here is to stabilize the client by administering that supplemental oxygen via nasal cannula or maybe a mask. Now, what else is the reason why we are supposed to do this intervention? Well, again, this will buy time for further diagnostics and treatment. And this is something that nurses can initiate per standing orders, especially in the acute setting. So this is a very urgent action that you can immediately do. All right. And so when you're not going to apply this oxygen, this can worsen the hypoxemia, and also it will cause much more deterioration in this case. Now, what else do you think would be the appropriate nursing intervention for this anastomotic leak with developing sepsis? Well, the other option here is to administer IV fluid bolus as ordered. So take a look into the blood pressure one more time. It's tanking to 84/58. And this is a very bad drop from a blood pressure of 96/68. That is a significant drop right there. and the rising pulse rate, which is compensatory mechanism here. These are signs of sepsis because of induced vasodilation and capillary leakage. And so when we are administering the IV bolus, it could be a normal saline, maybe 500 mLs or 1 liter, or maybe a lactated Renner solution. This will help increase the preload. It will improve the cardiac output and tissue perfusion. It will help increase the blood pressure, will at least stabilize the blood pressure, perfusion to the bodily organs. And also, this is part of the sepsis protocol as part of the early fluid resuscitation and a standard in sepsis management. Now, what about the encouragement of deep breathing? Why do you think this is not appropriate here? Well, we know that deep breathing can enhance the lung expansion, and this is often used as post-op intervention to prevent atelectasis or improve mild hypoxemia. However, the sudden drop in the saturation and the sudden increase in the respiratory rate is actually beyond what breathing exercises can address. And so we need to administer that oxygen therapy as early as possible, because this is going to at least stabilize the patient. And also, this is already a systemic issue. The client is already going downhill as a complication of sepsis. There is much more demand for urgent stabilization, not like supportive measures like deep breathing. And the other one, application of a heating pad to the abdomen, is also incorrect here, because this can worsen the inflammation and infection in the abdomen. And it also lacks an evidence as an appropriate intervention for this case. And lastly, we have prepared for immediate surgery. This is something that you might do when you have finally stabilized the patient. And of course, surgery will be needed later if an anastomotic leak is already confirmed. But then again, you have to stabilize the client's circulation and perfusion. Right? Now let's move on to the two parameters to monitor, and let me go through the options first. So one of those options include pain level and mobility, temperature and skin color, oxygen saturation and respiratory rate, urine output, and blood pressure, bowel sounds, and appetite. So what do you think are the two correct answers here? One of those is the oxygen saturation and respiratory rate, since we know that the urgent objective findings that we are pretty much worried earlier are about the hypoxemia and the tachypnea. And so when we are using the O2 saturation and respiration as parameters, this will help evaluate the improvement in their respiratory status, and this is directly tied to the oxygen intervention. And this will help us evaluate if there is improvement in their oxygenation. And if there is no improvement, of course, you're going to see a decline in their oxygen saturation. Now, what about the other option here? We have the urine output and blood pressure. So these two parameters will help assess the perfusion and fluid response, which is also tied to the IV fluid bolus. And the blood pressure will help us evaluate if there is stabilization of their fluid volume. And if it is effective, of course, we will be seeing an improvement. There's going to be an increase in the blood pressure, showing that there is restoration of the volume. However, if it is not effective, we will probably see persistent hypotension, which really warrants a worsening septic shock. Another is the urine output. Normally, we are expecting about 0.5 mLs per kilogram per hour. If there is going to be an improvement, then we will see normal urine output hourly. However, if the intervention is not effective, well, then we will see low output or oliguria, which indicates poor kidney perfusion. And so this is going to hint us that we probably would add more fluid boluses as prescribed. Now, what about the other options here, like pain level and mobility? Why these two are incorrect? Well, we know that monitoring pain is useful for assessing the patient's comfort, but it doesn't directly measure oxygen or fluid impact. And also the pain may persist despite we have stabilized the client's blood pressure. Also, the temperature and skin color can help in tracking any kind of like infection or worsening infection, but this is something that would be reflected a little bit slower due to the changes, and it doesn't directly assess the oxygenation and the effects of fluid resuscitation. Lastly, we have the bowel sounds and appetite. Absent or altered sounds might hint ileus or peritonitis, but these two are not urgent in a systemic crisis and do not really evaluate the interventions that we have provided to the patient. And the same thing with the appetite. This is irrelevant because a septic patient is not eating around this time, right? Of course, the client has a nasogastric tube in, so appetite would not really be a good parameter here. So I hope that you're able to capture all those answers for the 5 boxes. Now let's move on to our next item, and this is a matrix multiple response. So let's get into the scenario here, which says an 87-year-old man previously diagnosed with high blood pressure and joint issues, but otherwise relatively healthy, came to the emergency department complaining of difficulty breathing after slight activity and discomfort in his chest. He walked into the ED using a cane for support. After evaluation, he was admitted to the hospital, fully aware and coherent, with a confirmed diagnosis of heart failure. The nurse's initial check showed a blood pressure of 118/74, temperature of 98.5 degrees Fahrenheit, heart rate of 89 beats per minute, with a noticeable systolic murmur, breathing at 24 breaths per minute with mild effort, oxygen levels at 89% on room air, and subtle crackles in both lungs. Tests revealed an ECG displaying ventricular hypertrophy and an echocardiogram indicating an enlarged left ventricle alongside a narrowed aortic valve. So the instruction here is to click the nursing actions listed below to classify them as indicated, contraindicated, or irrelevant for the patient's current needs. So let's go through each nursing action. So for the first one, we have check the bowel sounds before each meal. What do you think about this? Is this indicated, contraindicated, or irrelevant? The answer is irrelevant because assessing the bowel sounds prior to the meals is unrelated to the management of aortic stenosis or heart failure unless a gastrointestinal complication is present, which is not noted in the case. So the care for this patient should focus on the cardiovascular stability and perfusion, rendering this assessment very unnecessary. Now let's look into the second intervention, which says turn the patient onto their left side. This is also irrelevant because this does not influence the left ventricular outflow or the venous return in aortic stenosis. And the primary issue is the mechanical obstruction, which is unaffected by this positioning. So unless otherwise indicated, this nursing intervention has no significant impact on the patient's cardiac status, and this is not a priority. The third action says ask for physical therapy consultation to initiate range of motion activities. Alrighty, go back into the case scenario. Your patient has, So the answer is contraindicated. The reason for that this is contraindicated because your patient already has some issues, let me put in my pen, with left ventricular enlargement. There is also narrowed aortic valve. The client's respirations at 24 breaths per minute with mild effort. And on room air, they're only saturating around 89%. There's also crackles in both lungs. So this is a patient that is actually having congestive heart failure. And so if you're going to ask for physical therapy referral for ROM, this is not a good idea, especially that physical activity, including ROM, will raise the heart's need for oxygen in the aortic stenosis, wherein the blood flow is already restricted due to the valve narrowing, the heart muscle. There's also thickening. And so with this can actually add more stress and workload, which will worsen the client's symptoms. And the decreasing blood flow to the vital organs will also make physical therapy unsafe and could be much more dangerous in the client's current state. Now, what else do we have here? We have request an order for a beta blocker. What do you think about this? Is this going to be indicated or contraindicated or irrelevant? You got to keep in mind here, guys, about the blood pressure of 118, which is actually pretty decent here. And take a look into the client's heart rate as well of 89 beats per minute. And in this intervention, it's talking about a beta blocker. Do you think that this is contraindicated or indicated? Well, the answer to this one is indicated. And the reasoning for that's because the beta blockers will slow down the heart rate. It will lessen the strength of the heart contractions, which will help reduce the strain on the narrowed aortic valve. And so this will allow the left ventricle to fill more effectively. It will ease the outflow blockage, and it will decrease the heart's oxygen needs. And in patients with both heart failure and aortic stenosis, the beta blockers will support better heart function and also considered as a beneficial treatment option. So I want to emphasize here that this patient is not really decompensating. And when I'm saying decompensating, there's actually worsening of the heart failure. And the patient is so unstable. And this is not what we are seeing in this case. And if I'm saying decompensating, beta blockers are usually contraindicated. But we are not seeing those the client is not really decompensating in this scenario. That is why it is not contraindicated. Now, what else do we have? Organized care activities to promote longer periods of patient rest. What do you think about this one? This is indicated because in aortic stenosis, the limited cardiac output and higher oxygen demand by the heart will reduce the blood flow to the tissues. And so when you are grouping the nursing tasks, this will help conserve the patient's energy by lowering their physical stress, and this will improve the blood return to the heart, and it supports its function. And that is also consistent with the goals for maintaining patient stability. Now, lastly, we have obtain a prescription for nitroglycerin to manage chest pain. What do you think about this one? I want you to recall about the drug effect or the drug action of the nitroglycerin. Well, in this case, this is going to be contraindicated because when the client has aortic stenosis, it blocks blood flow from the heart ventricle to the aorta during the systole. It will cause the heart muscle to thicken and increase its need for oxygen. And I want you to remember that nitroglycerin works by widening the veins it will lower the preload, which can reduce the amount of blood returning to the heart, and this can worsen the obstruction. And as a result, it may increase the chest pain and further reduce the cardiac output. So this is unsuitable for this patient's condition. So for you to answer this question, I want you to strategize carefully. You have to focus on the assessment, the planning, and safety, especially prioritizing your interventions that maintain the perfusion and also prevent the complications, especially in this case of aortic stenosis with CHF. And since the patient has both problems, you need to prioritize actions that maintain cardiovascular stability, something that will help conserve their energy and prevent further cardiac decompensation. And you have to rule out irrelevant options by asking yourself, does this intervention address perfusion, or does it reduce the cardiac workload? Another thing that you can do here is to identify the contraindications by recalling, could this action worsen the outflow obstruction or oxygen demand? And I want you to choose those indicated actions by recognizing the interventions that will help enhance the cardiac efficiency, such as using the beta blockers, activities, or something that could promote rest and decrease metabolic demand. So that's why we want to schedule or cluster the interventions to allow the client to have better rest periods. And you have to make sure to avoid increasing cardiac workload. So anything that would unnecessarily increase their physical activity is a big no-no. And also the administration of nitroglycerin is contraindicated because this is going to reduce the preload. Now let's move on to our third scenario. It says, highlight the patient's assessment findings that should raise concern for the nurse. The nurse's notes state, at 10:05 in the morning, a 34-year-old female with a history of metabolic syndrome, elevated blood pressure, and type 2 diabetes presents to discuss weight loss options, reporting a struggle with excess weight since adolescence and unsuccessful attempts with various diets, noting an 18-pound weight gain since her last visit from 302 pounds to 320 pounds, irregular menstrual periods for the past 6 months with no consistent cycle, and dyspnea after walking short distances with her husband despite efforts to remain active. Vital signs: blood pressure 170/95, heart rate 86, respirations 12, temperature 98.6 degrees Fahrenheit, height is 5 feet 6 inches, weight of 320 pounds, waist circumference of 40 inches, and BMI of 51.6. We have physical examination, reflexes 3+ throughout, no edema in bilateral lower extremities. The labs: high density lipoprotein of 30 milligrams per deciliter and low density lipoprotein of 160 milligrams per deciliter, and total cholesterol of 280 milligrams per deciliter, triglycerides of 183, blood glucose of 195 milligrams per deciliter, and the BUN 20 milligrams per DL, creatinine of 0.9 milligrams per deciliter, and hemoglobin 11.2 grams per DL, and hematocrit of 35%. So I want you to capture all those significant findings that should be something that should concern the primary nurse in this case. So one of those phrases that you should highlight is this. We got history of metabolic syndrome, elevated blood pressure, and type 2 diabetes, because these conditions are serious long-term health problems that will make her more likely to get heart disease or other issues. And the metabolic syndrome is a mix of conditions like high blood sugar, hypertension, and unhealthy fat levels. And in her history of hypertension and diabetes, she's at risk for things like a heart attack or a stroke. And the nurse here should watch her closely, because these conditions can quietly get worse and can cause unnecessary trouble. Now, another thing that you should highlight here is excess weight since adolescence and unsuccessful attempts with various diets. Well, this client has been overweight for years and cannot lose it despite trying hard. And being overweight since she was a teen shows this is not a new problem. It is deeply rooted. And the failed diets mean regular weight loss methods are not working, which could frustrate her and make her health worse, such as having diabetes and breathing issues. And the nurse here should the nurse should include this, because this is a sign that this client really needs special help, not just putting them into another diet. Right? So I hope that you were able to capture that. Another thing that you should highlight is noting an 18-pound weight gain since her last visit. So this client gained a lot of weight since her last checkup, and gaining 18 pounds in a very short time is not normal. It could mean her body's holding extra fluid, or her eating habits have changed, or something like her heart or hormones is really off this time. And for someone already obese with health issues, this sudden increase is a warning sign that the nurse should not ignore. Now, what else do we have here? There is irregular menstrual periods for 6 months, for the past 6 months with no consistent cycle. So identifying this basically reflects that her periods have been unpredictable for half of the year, and around her age, she's only 34. Her periods should be regular unless something's wrong. Could be a hormone problem, could be a PCOS, which ties to her weight and diabetes, or maybe stress on her body. And this new issue could mean her health is shifting in a very bad way. So the nurse needs to dig deeper here. Now, what else you should highlight? We have dyspnea after walking short distances with her husband despite efforts to remain active. So the client is getting really short of breath just walking a little, even though she tries to stay active. And the trouble in their breathing after short walks is not normal. It could be her heart, or it could be the lungs struggling under her weight, or maybe another health condition. And so since she is trying to move, but she still can't, it's a sign something is really gravely wrong here, and the nurse should worry about her safety and comfort. What else we need to highlight here? Well, obviously, the blood pressure of 170/95. This is way too high, and this could put her at risk for a stroke. It could damage a lot of the organs. Could be the heart, could be the kidneys if it stays that high. And so the nurse should act fast to get this under control. Another is the weight of 320 pounds. She's really heavy right now, more than ever before. And this could further do a lot of stress into her joints, her heart, and her respirations. And the fact that she went up from 302 pounds, it shows things are heading in the wrong direction. And the nurse should care, because this weight makes all her other problems harder to fix. Now, what else do we have? There's that waist circumference of 40 inches. All right. So a waist over 35 inches for women means extra fat around her organs, which is part of a metabolic syndrome. And that fat can mess up with her heart, her blood sugar. So even if it's not new, it's still a reason for the nurse to stay worried. Now, what else do we have? We have a BMI of 51.6. So ignore about the 40 inches there, because that was just an error. It's repetitive. And so the client here is extremely overweight, and any BMI over 40 is severe obesity, and 51.6 is way past that. It means her weight is a major health threat. So you got to think about heart disease, diabetes getting worse, or trouble moving. So the nurse here should be concerned, because this is a number that screams high risk. What else do we have here? We have the laboratory values. One of those is the high density lipoprotein of 30 milligrams per DL. So the good cholesterol is too low, and this is supposed to protect her heart. And 30 is below the safe level for women. And the low high density lipoprotein means her heart's more at risk, especially with her other issues. What else do we have? We got the LDL of 160 milligrams per deciliter. The bad cholesterol is too high. This will clog the arteries, and for someone with her condition, this could lead to a heart attack down the road. Now, what else do we have? We have a total cholesterol of 280 milligrams per deciliter. So this is way up, and this should be under 200. And it's a combination of her low HDL and high LDL. So it's really painting a very bad picture for her heart. Now, the triglycerides is also included here. We have 183 milligrams per deciliter. Her fats in the blood are higher than they should be. Supposedly, it should be a lot lower. Okay? With her diabetes and weight, the nurse should watch this closely. Now, what else do we got here? We have a blood sugar of 195 milligrams per deciliter. This is super high. The normal fasting sugar is under 100. And the high blood sugar can damage her eyes in the long run, the nerves, and even lead to emergencies if it spikes all the more. Now, what else do we got here? We have hemoglobin of 11.2 and hematocrit of 35%. So the H and H are also affected here. So the hemoglobin should be around 12 to 16 for women. And so the client here is slightly anemic. So that could explain her breathing trouble and tiredness. And it might tie to her chronic disease as well. And the nurse should not ignore this as well. Hematocrit, which is the reflection of the red blood cell concentration against the plasma, is also low. So it simply means that there is less blood carrying oxygen. So it's making her symptoms worse, like the dyspnea. So for this test item, I want you to identify the abnormalities and the clinical significance. And the task, again, is for you to highlight the findings that should raise concern. So it simply means that you need to capture all those unusual findings or anything that will put her at risk. And so since the client is actually going to, since she is discussing about weight loss options, the nurse here must identify the findings tied to obesity complications. We have weight gain, dyspnea, and factors that could affect the surgery eligibility or the outcome. So we have the uncontrolled diabetes, the hypertension. And so what you need to do in this test item, make sure that you scan the nurse's notes very well. And you got to capture all those abnormal vital signs, the manifestations. You have to compare the normal ranges of the vital signs, also with the lab values. And you have to assess the clinical impact. Ask yourself, why does this matter? And also link each finding to a potential health problem such as high blood pressure. It can lead to heart strain. And also prioritize their relevance. You have to focus on findings that are tied to obesity effects, such as the weight, the BMI, the waist circumference, and the bariatric surgery risks, such as the glucose that is so high and the other lab values. So when you go through the nurse's notes, pay attention to the history. The client has metabolic syndrome, hypertension, diabetes, which are not really common in a healthy 34-year-old. And so these three signal chronic risk like heart disease. So this is a big concern. Now also pay attention to the manifestations, especially the dyspnea, right? Even when she's just walking through a few distances or short distances, dyspnea after short walks is not typical. It suggests that her weight or maybe heart is actually being stressed way too much. and this shows a functional decline. Now also pay attention to the blood pressure of 170/95, which is way above the cutoff normal, right? This is an immediate risk. And also don't forget about the significant laboratories, the hyperglycemia, the lipid panel. All her values in the cholesterol panel are all whacked. And also the hemoglobin and the hematocrit needs to be addressed as well. So I hope that you were able to capture all these things. Let's move on to our next item. The scenario is a drop-down cloze, or the test item is a drop-down cloze, and it says a 64-year-old woman with prior diagnosis of asthma and type 2 diabetes mellitus began feeling a sharp burning pain while urinating, along with soreness in her lower abdomen and an increased urge to use the bathroom over the past few days. After trying to ease her discomfort by consuming extra fluids, she went to the emergency room with her daughter, describing additional symptoms of aching in her right flank, a high temperature, and overall fatigue. Her daughter observed that the patient, who is usually clear-headed and attentive, now seems confused. And urine analysis indicated the presence of bacteria, red blood cells, and clusters of white blood cells. The patient feels nauseated, is disoriented to place and time, experiences generalized weakness, has tenderness on the right side near the ribs and spine, and has a fever of 102.8 degrees Fahrenheit. So your task is to select the most probable choices to fill in the blanks in the statement below using the options listed. So the statement says, from the patient's assessment findings, the nurse concludes that the patient faces potential risks for issues such as blank, blank, and blank. And the options that we got are septic shock, low blood sugar, allergic reaction, chronic kidney disease, urosepsis, fluid volume overload, lower urinary tract infection, and acute injury. So I want you to use the options carefully here. And one of the first answers that we got here is urosepsis. This is a severe bloodstream infection originating from the urinary tract and often progresses from an untreated or complicated urinary tract infection. And the patient's symptoms strongly support this because of the presence of bacteria in her urine. There's also hematuria, and the white blood cells in the urine indicate an active urinary tract infection with inflammation and possible kidney involvement. Now, the client is also manifesting systemic symptoms. She has fever, there's nausea, there's generalized weakness, confusion, and these all suggest the infection has spread beyond the urinary tract and also affecting the whole body, which is a hallmark of urosepsis. Now, you got to go back into the history that the client has burning urination, there's lower abdominal soreness, there's frequent bathroom urges, which started days ago, and there is also escalating right flank pain. This is indicating possible kidney involvement, or I'll call this pyelonephritis. And so this is consistent with a urinary tract infection progressing to urosepsis. Now, go back into the age of the client. She is 64 years old, and this client is a high risk, especially with her age and her history of diabetes, especially. And so if there is an untreated UTI, it can quickly become urosepsis, especially with evidence of systemic involvement. There's that fever, confusion. And so the urosepsis is a big deal here. Now, what else do we got in this statement? We have septic shock, which is also a life-threatening progression of sepsis where the infection can cause profound circulatory and metabolic failure. This can lead to dangerously low blood pressure and will affect general organ dysfunction. And the client's fever of 102.8 degrees Fahrenheit, the confusion, the nausea, and the generalized weakness indicates that the client has sepsis, which is a precursor to septic shock. And the confusion in an otherwise alert patient suggests that cerebral hypoperfusion is going on, or there is metabolic disturbance, which is also common in sepsis. And the supporting evidence also include the bacteria in the urine, also in the blood. There's probably casts in the urine, and the flank pain also point to a urinary infection as the likely trigger, and this also aligns with a urosepsis potentially advancing to septic shock. Now let's move on to the next blank. And so the last but not the least, we have acute kidney injury. Why? Well, we know that AKI is a sudden reduction in the kidney function, and this is often caused by the infection, hypoperfusion, or obstruction. And the patient's presentation supports this risk. There's already the pain near the ribs and the spine, which we call this costovertebral angle tenderness, which suggests pyelonephritis, which is basically a kidney infection, which can also impair the kidney function. Now, the bacteriuria, the hematuria, and the white cell cast in the urine indicate the infection and the inflammation in the kidney, and this can potentially damage the nephron, which will lead to the acute kidney injury. Now, why is this a risk? Well, of course, this is an ascending urinary tract infection. It starts from the lower tract to the kidneys, which can directly or indirectly cause hypoperfusion, which will lead to poor kidney function. Now, what about the other options here, such as low blood sugar, or basically hypoglycemia? Well, this is incorrect because the hypoglycemia occurs when the glucose drops too low. It can lead to confusion, sweating, or shakiness. But in this scenario, there's only a few supporting evidences that will coincide with the hypoglycemia, such as the confusion. But then again, this is not going to really coincide with the rest of the manifestations. There's no mention of sweating. There's no mention of hunger. Or let's say maybe an overdose of insulin, which will support hypoglycemia. That's why we're going to get rid of this one. Now, allergic reaction is incorrect because this one involves immune response to an allergen, which potentially cause itching, rash, swelling, or respiratory distress. And this is a mismatch to the overall manifestations because there are no symptoms like rash, there's no wheezing beyond asthma history, or anaphylaxis. And asthma is not active in the scenario. There's no dyspnea mentioned. So we're going to disregard this one as well. Now, what else? We got chronic kidney disease. This is also incorrect because CKD is a gradual. This is a long-term loss of kidney function, and this is often linked to diabetes or hypertension. And the symptoms the client is experiencing started days ago. So this suggests an acute process. So acute kidney injury would better fit on this one, not chronic kidney injury. Now, what about fluid volume overload? Why is this incorrect? Well, it's because this only occurs when the body retains excess fluid. This will potentially cause edema, shortness of breath, or hypertension. But here, the scenario did not mention about swelling or lung crackles. The patient increased fluids at home, but this did not cause overload symptoms. And with sepsis or shock, this can actually lead to hypoperfusion, not fluid overload. Now, what else do we have? We have lower urinary tract infection. This is also incorrect because a lower UTI affects the bladder or urethra. It can cause burning and urination, urgency, and lower abdominal pain. Initially, it's possible, but the client is actually now manifesting much more systemic signs and symptoms. They're already manifesting flank pain, fever, confusion, urine casts, which indicate it has already ascended to the kidneys. We call that pyelonephritis, and this is complicating into urosepsis. And a simple urinary tract infection would not explain the systemic symptoms, such as the fever, confusion, or the renal tenderness in the diabetic patient after days of progression. So I hope that you're able to capture all three correct answers. Let's move on to the next item. This is a extended multiple response, select N. So the case scenario states, a 67-year-old overweight man with past diagnosis of type 2 diabetes visits his primary care provider to review findings from a sleep study, which revealed obstructive sleep apnea. His wife, who is with him, notes that her husband snores loudly, pauses breathing for several seconds, and then gasps and snorts multiple times each night. The patient mentions feeling very fatigued during the day and unrested upon waking. So your task is to select 3 clinical manifestations that the nurse would anticipate observing to confirm the patient's condition, which is the obstructive sleep apnea. So you're only allowed to pick 3 observations. So what are those 3? The first clinical manifestation is reduced muscle strength during the day. What do you think about this one? Do you think that this is correct? Reduced muscle strength. But before we go to do that, let's actually pick the correct answers here. And so one of those is headache upon waking. Why? Because this is a well-documented manifestations of obstructive sleep apnea due to the physiological changes during the sleep. And with obstructive sleep apnea, the upper airway partially or completely collapses. So this can lead to repeated apneic episodes, or what we call a cessation of breathing for more than 10 seconds. And the episodes can actually cause hypercapnia. There's going to be a buildup of carbon dioxide in the blood during their sleep. There is lack of ventilation. This will cause dilation of the cerebral blood vessels. This can also increase intracranial pressure overnight. Also, with the reduction of the oxygen levels, this can lead to hypoxemia. It can exacerbate this effect, contributing to the vascular strain. And the frequent arousals will actually cause sleep disruption. It will prevent deep, restorative type of sleep, and that's why it can amplify headache. Now, what else do we got here? We have erectile dysfunction. Why is this correct? Well, the impotence is a recognized complication of obstructive sleep apnea, which is linked to impact on the hormonal and vascular health. Now, remember that I mentioned about the hypoxemia's effect with the repeated drops in the oxygen saturation during their sleep. This can impair endothelial function. This will reduce the blood flow needed for erections. And the obstructive sleep apnea, which disrupts their sleep cycles, can also lower their testosterone production, which is critical for sexual function and typically peaks during the deep sleep. And the chronic fatigue can also happen due to the sleeplessness during the nighttime. They're going to be too exhausted during the daytime, as reported by the client, which will also further reduce their libido and performance. And take a look into the patient's age. He is 67 years old, obese, and has history of diabetes as well, which already increased their risk for ED. And also the obstructive sleep apnea will cause additional burden. This can lead to hypoxemia, sleep loss, making this a very plausible manifestation. Now, what else do we have? We have patient mentions trouble focusing. What do you think about this one? Well, the decreased concentration during the day is a hallmark of obstructive sleep apnea due to the chronic deep absence of sleep or decrease in the sleep And the apneic episodes can actually cause partial arousals. It will prevent the patient from reaching deep restorative sleep stages. And this can also cause some cognitive impact. This is going to make the patient feel so very fatigued, unrested. It will impair their attention, memory, and focus. And the low oxygen levels during the apneic episodes may also subtly affect their brain function, so it can compound cognitive difficulties as well. And the patients complain that they are extremely tired and feeling unrested directly ties to the poor sleep quality from the obstructive sleep apnea. Now let's look into the incorrect options, such as the reduced muscle strength during the day. Why is this incorrect? It's because the loss of skeletal muscle tone during the day is associated with cataplexy, which is a feature of narcolepsy, not obstructive sleep apnea. And with cataplexy, this involves sudden muscle weakness, and this is triggered by emotions, could be laughter, leading to collapse. And this is a big contrast to the obstructive sleep apnea, which involves airway obstructions without daytime muscle tone loss. Now, what about wife observes more leg or arm activity during sleep? What is this? This is basically referred to as involuntary limb movements during sleep, and this is characteristic of periodic limb movement disorder, or we call as PLMD, not obstructive sleep apnea. So with PLMD, this is going to involve repetitive leg or arm jerks during sleep, and this will disrupt the client's rest period, while the OSA centers on the airway obstruction. There's that snoring, there's that apnea, there's that gasping, or maybe snorting, right? Now, what about lowered oxygen levels during the daytime hours? Why is this incorrect? Even though the obstructive sleep apnea causes hypoxemia during sleep, but daytime oxygen saturation typically normalizes unless there is another condition. Could be another lung disorder or maybe a heart disease is present. And so the apneic episodes of this client causes lower oxygen at night, but the waking can help restore the normal breathing. So it will eventually correct the saturation unless there are any other comorbidities that is present. And so the daytime oxygen levels should be normal in an uncomplicated type of obstructive sleep apnea. So this is incorrect. Now, what about weekly weight reduction of 2 to 3 pounds? Well, weight loss is not a manifestation of obstructive sleep apnea. Obesity is a risk factor, not a consequence. And the patient's overweight status contributes to the obstructive sleep apnea by narrowing the client's airway. But the obstructive sleep apnea itself doesn't cause weight loss. And there's no mention of weight changes or diet or illness suggesting weight loss here. So this is not really a best fit here. And there's no physiological link between obstructive sleep apnea and spontaneous weight loss. And this would require an unrelated process, maybe another illness or an intentional effort, but it's not indicated in the case.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
Let's move on to our last item. We have a drop-down cloze. So let's go through the scenario here. It says the nurse is preparing educational sessions for multiple patients beginning treatment with different antihypertensive medications. So your task is to identify the educational point from the leftmost column corresponding to each commonly prescribed antihypertensive drug. So we have the potential education points. The first statement says, when paired with thiazide diuretics, this medication is the preferred initial treatment for African Americans. So we have the selections at the bottom. We have options none, amlodipine, losartan, metoprolol, lisinopril, and hydrochlorothiazide. So in this test item, I want you to remember the drug classifications of each drug and make sure you recall the drug action and their side effects or adverse reactions. So what do you think would best fit the first statement? What do you think among the options here? The answer here is amlodipine. And why is that? Remember that amlodipine is a calcium channel blocker that works well thiazide diuretics to lower the blood pressure. And according to the guidelines, this recommends this combination as the first choice for the African Americans because it is more effective for their type of hypertension, which often responds better to these two drugs other than the ACE inhibitors or the beta blockers. Now, what about the second statement? Keep track of your blood sugar levels at home as this medication may elevate glucose levels. Well, go back into the options. The answer to this one is none, because none of the listed medications can cause elevation can cause significant elevation of sugar to make to push for regular home checking. Even though the hydrochlorothiazide is known to slightly increase the glucose, but the effect is very little. And it's also rare at standard doses, and it doesn't typically require routine home monitoring unless the patient has pre-existing diabetes or other risk factors, and that's why the answer here is none. The third statement, it says, check your pulse regularly at home, and since this medication can significantly slow your heart rate. Among the options, what do you think would best fit here? The correct answer is metoprolol, which is a beta blocker, which can slow down the heart rate and also lowers the blood pressure. And patients that are supposed to take this drug should check their pulse at home to catch if it drops too low for them, which could cause dizziness, can cause undue fatigue, and none of the other drugs in the list affect the heart rate like this one. Now let's move on to the next statement. It says, take this medication at bedtime as it might cause stomach upset or vomiting. Take a look into the list. The correct answer here is none. None of the medications in the list can cause nausea or vomiting bad enough to require taking them at night. So this teaching doesn't fit any of them well. Let's move on to our next statement. It says, make sure to include potassium-rich foods in your diet, as this medication may lead to potassium depletion. The answer is hydrochlorothiazide. This is a thiazide diuretic that removes sodium and water, but also the potassium. And so eating potassium-rich foods such as bananas can help prevent problems like muscle weakness or heart rhythm issues. The other drugs do not really cause potassium loss. Now we have our sixth statement. We have inform your provider if you experience a persistent dry cough, a frequent side effect of this medication. The answer is no other than the known lisinopril. This is an ACE inhibitor that will cause the dry, nagging cough because it affects a chemical in the lungs, the bradykinin. And patients should tell their doctor if it happens because they might need a different medication. And the side effect is unique to ACE inhibitors among the options. Lastly, we have note that certain batches of this medication have been discontinued due to safety issues. There's no other than losartan. Remember about the classification of this drug. This is an angiotensin receptor blocker, and some batches were already pulled from the US market because they had possible cancer-causing contaminants. And this safety concern is specific to losartan, which is an ARB. And the other drugs are not related to this one. So I hope that you were able to correctly select these answer options. And yeah, this is a very good part of your review, since this is really taking, or this is going to make you focus your attention into the different side effects and the newer recommendations, and also newer information regarding the drugs such as the losartan. And you got to pay attention to the side effects here, the precautions that you should be teaching to the client as well. And so this ends our session today. I hope that you were able to learn some stuff, and I want you to review on what you have absorbed, walk through the practice sessions one more time, and continue strengthening your test-taking skills. And if this video was useful, don't forget to hit the like button and subscribe for more NCLEX prep resources. Also drop a comment below to tell us how you did in these practice tests, and we'll see you again in the upcoming video. Thanks for watching.